Good morning and welcome to the Emergency Medicine Management of Opioid Use Disorder Frequently Asked Questions presentation. This is a partnership between the Michigan Opioid Partnership, California Bridge, the Community Foundation for Southeast Michigan, and MHA Keystone Center. I'm Nick Rademacher. I'm an emergency physician currently working in Grand Rapids, Michigan, and I am a technical assistant and clinical consultant with the Michigan Opioid Partnership, where we help emergency departments across the state of Michigan implement opioid treatment pathways. I am joined today by Andy King. He is an emergency physician in Detroit and is board certified in toxicology and addiction medicine, as well as Ariana Campbell. She is a physician assistant who works in the emergency department in California. She is a leader within the California Bridge project as they also attempt to expand opioid treatment programs throughout their emergency departments. I'm happy that we're all able to provide some information and frequently asked questions that all of us have had during our efforts to expand treatment access for opioid use disorder. So we are first, we already did our welcome and introductions. And in just a moment, we're going to start talking about these frequently asked items that come up over and over again as we talk about medications for opioid use disorder with emergency departments. At the end, there will be some time for questions and then a brief closing. Today, we hope that you will gather that medications are the most effective treatment for opioid use disorder and recall some of the questions that we get asked frequently and the concerns that others have, and then be able to come up with some evidence-based responses if you happen to get these questions from other providers, nurses, or patients. We like to help people recognize that many of these questions and their hesitancy is rooted in the history of opioid use disorder treatment and stigma associated with it. And we hope that you can support an inclusive, welcoming environment for patients with opioid use disorder.
Okay, and so I'm Ariana Campbell. Thank you for getting us started, Nick. All right, so I wanted to, let me go to my first question. Okay. So here's a question that I actually asked. So this was something, actually, I made a statement when somebody approached me about giving buprenorphine in the emergency department setting. I said, well, isn't the treatment of opioid use disorder with medications, is that something we really should be doing from the emergency department? It was my understanding that this was this hyper specialized field that could not be performed in the emergency department. And I honestly had this question after 17 years of practice in the emergency department. So I'm going to help lay out I was re-educated and really was able to look at evidence that showed that I really should be treating opioid withdrawal, opioid use disorder with the right thing in the emergency department. So this is the first study, actually, here, that I'd like to point out. Actually, let me go back here. Okay, so there was a study done in Massachusetts from 2011 to 2015, and what they found, first of all, without any treatment of opioid withdrawal in the emergency department, there's this really high risk of mortality after a non-fatal overdose. I mean, it's actually along the lines of, post STEMI. So if somebody has a heart attack, their mortality in the first year is really close to a non-fatal overdose. And these are 20-year-olds, 25-year-olds, right? So let's take a look at this. So short-term non-fatal overdose, not given medication to treat opioid use disorder from the emergency department, 1 in 20 will die in the first year, and of those who die, 1 in 5 will die in the first month. And here you can see this is those first 30 days after a discharge from the emergency department after a non-fatal overdose. And just look at that first day. Look at the death rate on that first day. So of those, 1 in 5 will die within the first day after a non-fatal overdose. So this is an overdose epidemic. We are treating overdoses in our emergency department. We have to acknowledge that there's significant mortality in the first 24 hours after a non-fatal overdose. And this is the reason to really own this in the emergency department and make sure we're providing evidence-based treatment. So let's also talk about, let's say somebody comes in for any medical problem. Maybe, maybe they have an abscess, maybe they have endocarditis, so they're hospitalized. So initiating treatment from the emergency department and hospital is incredibly important. Why? Because if we are not treating with medication, let's say this is a study from 2015, let's say we get folks off of opioids, right? So they're in our hospital and we get them off of all opioids and we don't give medication, the right medication to them, then their risk of dying 28 days after discharge is huge. So drug-related death jumps after hospitalization, including in that first 28 days, in the first 1 to 3 months, and even out to 1 year. So again, really high mortality in this first month after emergency department or hospital visits for drug-related or non-drug related issues if we're not providing treatment. So again, what an opportunity to treat and decrease mortality. So we can also look, I hear a lot of people ask questions, well, if we do this in the emergency department, why are we doing this here? Are we attracting patients? We already have folks in our emergency departments who have a substance use disorder diagnosis. This is 17%, and that's what's reported. I believe this is underreported. And if you just look at your tracking board right now, you'll probably find a lot higher percentage of folks in your emergency department right now who have some related substance use disorder associated with the reason that they're there today. And for every 1,000 people over 15, there's 25 drug-related, specifically drug-related emergency department visits. And of all patients, even if it's not drug-related or substance use disorder diagnosis associated, 28% will screen positive for a substance use disorder. So again, looking at your tracking board, almost 1 in 4, more than that, are going to have a substance use disorder related issue. So what we can tell you is treatment, so you might say, well, a lot of people have substance use disorders. They're in my emergency department. Yes, they're in my hospital. Bringing them into the emergency department hospital increases their mortality, right? That's what we're looking at. So if they come in, their risk of dying increases afterwards, after a hospitalization. But if we're actually giving treatment, we can decrease their mortality. So this is treatable. So again, this is something we can do something about. So you can look at the general population. This is a standardized mortality ratio. This is from a study in 2017. So with no treatment at all, there's this significant increased mortality rate. But you can see when we give medication, and we call it medication-assisted treatment or medication for addiction treatment, we decrease their risk of dying from any cause by more than 50%, and it gets it closer to the general population. So again, mortality, there's a study done here. This is actually in and out of French office-based general practice. Actually in France specifically, there is a lot better access to medications. They don't put as many regulations on it, but you can see that there's a 10-fold decrease in mortality with folks who are in buprenorphine treatment over a 7-year cohort study. And this is just continues more evidence that there's a significant decreased mortality during and after medication treatment for opioid use disorder. So this was just a big meta-analysis cohort study, but you can see that there's a significant decrease in mortality for treating with medication. So this is from Sarah Wakeman, 2020. Sarah Wakeman did compared actually counseling and medications and different medications, methadone and buprenorphine, and it was very clear that versus that counseling, how often have we said, oh, you need to go get counseling? We have a 76% decreased risk of overdose at 3 months by giving medications. So medications are really the standard of care. Counseling can help in addition to that, but this is significant difference in terms of giving medications versus counseling alone. And again, even at 12 months, we have a 59% decrease in overdoses by giving medications. All right, so I am going to turn it over to you, Andy.
Thanks. Okay, the next question here is, isn't starting someone on buprenorphine just trading one addiction for another. And this is something that we hear not just from patients, but providers too. And we need to make sure that we unencumber these terms and disassociate them so we can talk about what they actually mean. And we're going to go through physiologic components of tolerance dependence, and then the combined disorder of addiction or substance use disorder. And again, these are obviously often confused and conflated like I have here. So let's go through these. Tolerance means that it takes more of the substance to get the same effect. And this is a real common thing that a lot of people run into, and it can happen with just about any medication. And so you're looking for whatever the desired effect is over time. As you're exposed to it multiple times in a row, you can develop a tolerance. And this can happen from things like nitroglycerin, where you can get like a tachyphylaxis response, to opioids, to alcohol, to benzos, whatever it might be. And then dependence really is just a physiologic adaptation that your body creates over time, kind of countermeasures to maintain homeostasis. That if you're constantly being subjected to whatever substance it might be, alcohol, benzo, opioid, that when you remove it, you have a withdrawal phenomenon, because the compensatory mechanisms that have developed over time now can shine through without, the actual substance on board. And then finally, the addiction, right? This is the loss of control, the compulsive use, and the negative consequences that you see with the addiction or substance use disorder. And that's what the difference is between dependence, right, which is just physiological, and addiction, which is all of the collateral damage that occurs with the use of the substance. And so the ASAM definition of addiction here, I just want to read aloud so everyone can understand where we're coming from, is that it's a treatable chronic medical disease. It involves complex interactions among brain circuits, genetics, environment, and an individual's life experiences. And people with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. It really is one of those kind of by rote things that they'll do, and not really put a whole lot of effort into thinking about it and planning. And so it just becomes one of those things that just becomes habitual for them. And then prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. And so that's important to know, is that we cannot have therapeutic nihilism here, because you can treat successfully a lot of substance use disorders. So when people are talking about and conflating the two terms of chemical dependence or dependence versus addiction, we need to be, upfront about this. Like, yes, medications for opioid use disorder like methadone or buprenorphine, you're going to be chronically exposed to it. So if you stop it, you'll have a withdrawal phenomenon. Like, that's the sine qua non of dependence, is that you have withdrawal. But they take care of the cravings, the compulsive use, and the consequences, right? Instead of going to use heroin and overdosing or injecting and getting endocarditis, or having those cravings that you just can't do anything about until you, satiate that feeling in your head. Now you have a medication that takes care of all of that, so you can focus on other things in your life, right? Like you can work on your relationships, and you can keep a job, and you can keep money in the bank, right? All of those consequences from use start to evaporate and go away over time. And so that's why the medications, even though they cause chemical dependence, they treat the addiction, they treat the substance use component part.
Okay, so the third question that frequently gets asked, or gets told to us, I guess I'll say, is that Suboxone has caused withdrawal. So this is usually patients that are telling me this, that, oh, they're not interested because last time they got sick, the naloxone made them sick. So they either don't want to try Suboxone at all, or the buprenorphine and naloxone combination tablet or strip, because that naloxone last time made them sick. So either give them just the buprenorphine, or don't want to, they don't want to do it at all. And this really gets into a question of bioavailability and route of administration. And so medications have different bioavailability, which is the fraction of active drug form in the systemic circulation. based on the route. And so if someone is going to get naloxone IV, then it's 100% bioavailable. It's all in the systemic circulation. But if they take it by mouth, intranasal, sublingual, that bioavailability differs. And so we know that naloxone is about 3% bioavailable if taken under the tongue. Intranasally, it's 30%. And then, of course, if it's given IV, it's 100%. So knowing this, let's do a quick case. So we have a patient, Joe, who takes 16 milligrams of buprenorphine, and 4 milligrams of that, the combination tablet is naloxone. So 16 of buprenorphine, 4 of naloxone. If you take that under your tongue, then 4 milligrams times 3% of naloxone is approximately 0.12 milligrams of naloxone that is bioavailable. On the other side is the buprenorphine, which has a pretty wide bioavailability between 25 and 60%. And so Joe is going to have between 4 and 9.6 milligrams of buprenorphine systemically available when taken sublingually. So you have these two medications. You have a small amount of naloxone, which if you gave someone on opioids 0.12 milligrams of naloxone, you can conceive that they could develop some withdrawal symptoms from that. But when you consider that they're having between 4 and 9.6 milligrams of buprenorphine, buprenorphine is very potent at the mu receptor. And not only does it compete with, methadone, heroin, fentanyl, but also naloxone. And so we know that 4 to 9.6 milligrams of buprenorphine would outcompete 0.12 milligrams of naloxone, which really does make the naloxone component inert. So it's a small amount that's bioavailable, and anything that is bioavailable will be outcompeted by the buprenorphine component of the medication. So the naloxone is not causing withdrawal for patients. But what is that they're experiencing? Why did they feel so sick when they took buprenorphine from a friend, or last time they got buprenorphine? Why did they not do well? Well, it's because you have this relative decrease. So if they were still flushed with systemic opioids, so if they were in fentanyl or morphine, that was a full agonist, and then they didn't wait long enough for them to start to go into withdrawal. When they take the buprenorphine, it's going to remove the fentanyl or morphine or other opioids from the receptor. And this change from a full agonist to a partial agonist will make them feel sick. And it feels just as if they've had naloxone, which many patients have had it, and they know what naloxone precipitated withdrawal feels like. It feels very similar to buprenorphine precipitated withdrawal, which is what they're experiencing when they take the combination tablet or strip with both buprenorphine and naloxone. So at the end of the day, it's not the naloxone that causes the withdrawal. It's probably the buprenorphine. And all we need to do is educate patients that if they wait longer, and so that they're not going to displace their long-acting opioids or longer-acting opioids, that they shouldn't have that experience of withdrawal. So a quick polling question: patients with opioid use disorder are at elevated risk of overdose at which of the following times? Is it A, 24 hours after ED visit for overdose, B, the year following hospitalization for drug treatment, C, while being treated with naltrexone, or D, A and B?
All right, so this is a question that I am asked all the time. And again, there's this comfort in sending folks for counseling, and there's been this discomfort when with medication. So the question has been, isn't it better to refer to patients to counseling first and then start medications after that? So let's talk about this. Just a moment. All right, so I'm going to start here with was a really pivotal study that we'll probably bring up time and time again. This is Gail D'Onofrio, who was the chair of emergency medicine at Yale, and she was actually looking specifically at this. It was the standard in the emergency department prior to the study being published in JAMA in 2015 to refer to counseling. I mean, most folks at some point have given somebody the list. So there's this list of places that folks can go for substance use disorder treatment, many of them counseling forward and really not advocating for medication, many residential treatment facilities that wouldn't allow medication. So she knew the efficacy, so the medications work. Medications decrease a person's risk of dying. So she wanted to see, well, what if we actually started those medications in the emergency department setting rather than giving counseling. She was also actually doing SBIRT, which is screening, brief intervention, and referral to treatment. So this was counseling and actually referral to treatment, a little bit better than what I was doing in my department. But she just made, let's take this group and actually give them medication in the emergency department, buprenorphine naloxone specifically. And what she found is that she more than doubled a person's likelihood of being in treatment in 1 month by simply giving the right medication at the right time. And that was buprenorphine to a person who is experiencing withdrawal. So this was really, really important. This was a prospective randomized controlled trial. And we won't see more of these because this is so definitive that we should be giving buprenorphine in the emergency department setting to somebody who is experiencing opioid withdrawal and opioid use disorder. So let's take a look at some more evidence. So again, this is emergency department initiated buprenorphine for opioid dependence with continuation in primary care. So this is it. This is really looking at how, when we give medication in the emergency department, how we can make this, increase this person's odds of continuing the same treatment that decreases their risk of dying from any cause, as we already established. And again, I go back to the Wakeman article, but MAT really is the standard of care. They looked specifically at giving medication versus counseling because, again, most emergency departments in the United States have just been referring to counseling, not providing medications, not even making sure the people we're referring to are giving medications, much less starting it in the emergency department. And when we treat with buprenorphine or methadone works as well. It's associated with a 32% relative rate of reduction in serious opioid-related acute care use at 3 months and 26% relative rate of reduction at 12 months. And in contrast, the antiquated model of detox and intensive behavioral health, those were not, also naltrexone treatment was not associated with reduced overdose or serious opioid related acute care use at 3 or 12 months. So this was a really very revealing article where we were able to take a look at the difference between the two different pathways that we historically offered. And it's very clear that we should be giving medication, specifically easier to give buprenorphine in the emergency department setting, but methadone's great too. And if somebody prefers methadone, I'll certainly give them methadone in the emergency department. And I go back to number needed to treat because if there's a lot of numbers that we're presenting today because we're tasked with really showing the evidence versus a lot of these antiquated beliefs. And if nothing else, just know that you only need to treat 2 people to retain in treatment at 1 month. So number needed to treat is a very simplistic number that you can you can repeat this to your friends, your coworkers, your emergency department, that you just need to treat 2 people to retain in treatment at 1 month by giving this medication in the emergency department. All right, I'm going to turn it back over to you, Andy.
I take my control back. Thanks, Ariane. All right, so I'm going to read this one out loud and we'll go through the evidence behind this too. So with fentanyl use, are patients more likely to experience precipitated withdrawal if a provider provides standard or high dose buprenorphine induction? And should we be starting patients with lower doses instead? I think that's, this goes back to some of the basic questions that a lot of people have been trying to refine over the past couple of years as we start getting more and more comfortable with using buprenorphine. And then there's been, some concern that the fentanyl, which has been increasing in the amount of, relatively in the heroin supply, is that throwing a monkey wrench in all of this? Is this really changing the way that people are responding to buprenorphine? So let's go see what the evidence shows. When you look at some of the articles that are out there, this one was from American Journal of Emergency Medicine in 2022. So brand new, hot off the presses. This looked at fentanyl and precipitated withdrawal. And there's some concern that fentanyl use increases one's risk of precipitated withdrawal. And so they went back and then they looked at what some of the risk factors of previous studies demonstrated, like what were those risk factors for precipitated withdrawal. And those included some chronic kidney disease, cirrhosis, people that were on methadone, fentanyl use, and then benzodiazepine use. And most guidelines out there had recommended, when buprenorphine first started being used as a medication for opioid use disorder, they would have these days where you'd go into clinic and they would give you these small doses over a prolonged period of time. And so you'd be in the office for most of the day. I work in a methadone clinic, an opiate treatment program, and some of the nurses have been doing this for quite a long time. I'm not going to use the number of decades that have been working in substance use, but they'd been there for a while, and they remember these inductions, just spending all day. They would give like a 2 milligram tablet, let them hang out for a little bit, do another 2 milligram tablet. So it became a big deal. And then, you had they remembered anecdotally, at least, at a relatively high percentage of the time that they'd have to call the ambulance because they were getting some precipitated withdrawal in the hospital or like in the outpatient clinic there. And then, so there was a nice convenience study that came along recently, and I'm going to show you in a second, that showed these bigger doses. And then, so that's anything over 8 milligrams or the macro doses, and then found a low rate of precipitated withdrawal. So the question is, like, is this kind of messing around with these smaller traditional doses, putting one at risk for actually precipitating withdrawal, whereas we should just be hitting them with one big slug, and then you're going to see the percentage of precipitated withdrawal, that incident actually decrease. And so this was a study by Dr. Herring et al. Again, relatively brand new in 2021, and they looked at high-dose buprenorphine induction in the emergency department for the treatment of opioid use disorder. A little bit of a journal clubbing here because you gotta know that the evidence is still evolving, but they did a retrospective chart review. They did a convenient sample of patients that they were starting on medications, and then they looked at patients that are the standard, like the 2 to 8 milligrams, or something high dose, which was over 12 milligrams. And then they looked at the rate of precipitated withdrawal. So this is a very busy slide, but what I'd have you take a look at is the very top here is that you have the milligrams of buprenorphine that were administered sublingually to people. And Nick showed you like what the bioavailability is. It's not actually, they're not getting that 2 milligrams, they're getting, a percentage of that. And then you looked at the precipitated withdrawal, which is down in the lower one. So these are the adverse outcomes. And so they saw in the 8 milligram dose, they had a number of precipitated withdrawals. And then you looked at the higher doses, they really didn't see a whole lot of precipitated withdrawals with one exception. And so that was one thing that suggests that, like, maybe if we start with these like normal doses of 8 milligrams, like for a long time I taught a lot of my partners that if you have a COW score of 8, clinical opioid withdrawal score of 8, give 8. It's easy, right? I'm not that smart a guy. I think it's like one of those things that you can always remember to do, like 8, give 8. Oh, okay, it sounds good. But maybe it should be like a little bit refined, and that's why I can't think of anything that rhymes with 12 right now. Dig and delve. I don't know. Ariana, can you help me out here? I'm not much of a rapper or a rhymer, but we gotta rethink some of these little easy mnemonics. So, and then there's also microdosing. And so now I think as more people get comfortable with buprenorphine, we're either saying like, give the bigger doses because that's the easier way just to get through it and decrease your risk of having precipitated withdrawal, or do it nice and slowly. And then we call these microdosing. And so there's a lot of these case reports. I got to say, I do this a lot in the hospital where I practice when we do addiction consults inpatient. We do this microdosing regimen. So you can keep people on a full dose opioid agonist, and then you gradually increase the amount of buprenorphine that you do, usually over a couple of day period of time. And as you do it, slowly increasing the amount that you're giving and increasing the frequency, that they don't have precipitated withdrawal. So like what Nick was talking about before is if you go from full opioid agonist to partial opioid agonist, like in a really short period of time, it's like that delta, that jerk phenomenon, right? Delta change over delta time. We're doing calculus today, Ariana. Isn't that amazing? We remember all that stuff, like we had to do calculus, but now we're doing it today. That is where the problem is. It's like if you change it too quickly, if you really saturate those receptors, that's where people are miserable and they're flopping around, they're sweaty and they're vomiting and they have a bad day. And so that's why, we're looking to find ways where we can really prevent and decreases the chances of that. And so we're really fine tuning these things. But the microdosing is one of those ways that we can keep that from happening too. So right now, like what is the right dose? Unfortunately, we don't have a lot of RCTs or prospective trials to tell you like what the right dosing regimen is. I think a lot of people are feeling more comfortable with these like small titrating doses over time. That's usually something that you do in the hospital. That being said, there's a couple of patients that I've done microdosing with on an outpatient basis and it's worked well. Or maybe instead of giving the 8 milligrams, we should be considering higher doses. Until more evidence emerges, I think that, whatever the case is, you really want to try to get someone into the average dose of 16 milligrams per day, as quickly as possible, because what Ariana showed is that, the lower doses, the number needed to treat starts going up on you, which is what we don't want, right? You start losing people from treatment if you're under treating them, right? And it's very a counterintuitive way to think about this is, you want to give higher doses, right? And I remember Nick brings this up quite often. It's like, it's very different way of thinking about this specific opioid when you think compared to other ones, right? You really want to try to get them to that therapeutic dose as soon as possible so you can retain them in treatment, because that's where the magic is Campbell has been bringing up, like with multiple studies. So, also pay attention to medical comorbidities. We have some risk factors, maybe if they have some renal insufficiency or hepatic insufficiency, and they have more of a reason to keep around fentanyl metabolites, that might be some theoretical reason why they're at a higher risk for having precipitated withdrawal. So just kind of pay attention to those things when you're looking at someone and trying to decide what the right dose is. You also got to pay attention to the age and comorbidities of the patient. So we really need to pay attention to these risk factors as we decide what the dose is going to be. I hand it over to Nick.
Great, thank you. All right, so usually this is from colleagues or people I'm trying to go through a treatment pathway with, where, if you have patients who are not yet in significant enough opioid withdrawal, that you really shouldn't give them buprenorphine in the emergency department because you'll precipitate their withdrawal. Typically, the treatment branch for those with a low withdrawal scale is to do a home induction. But many people are very nervous about having a home induction because, the providers themselves are nervous, and so they're just going to have patients go do it at home. Like, this makes them very uncomfortable. But I argue that it shouldn't. I think that majority of the time, if you talk to a patient, honestly, they'll tell you that they've tried buprenorphine before. Most of the time it goes well. Sometimes they've had precipitated withdrawal because they started too early, but that's more rare. And so patients are usually pretty familiar with the medication. There has been research over 10 years ago that showed that patients left to do this at home have over 90 or have a 89% success rate, almost 90%. And there wasn't a severe episode of precipitated withdrawal by buprenorphine during that study. So it's safe to do. It's what primary care and I think addiction specialists do primarily now is have patients start at home. And so you can be pretty confident your colleagues in other fields of medicine are doing this. And in emergency medicine, this has become part of the standard induction pathway as well. So feel free to do it. It's very important because I think most of my patients aren't in significant opioid withdrawal. I can't give them buprenorphine in the emergency department. When I first started doing this, I would ask them to come back in 12 or 24 hours during my next shift to get a dose from me. And that just made their life difficult. They rarely showed back up. So now I just write a prescription. I print off a home induction guide. I usually use the California Bridge induction guide. The Michigan Opioid Collaborative also has one. They're a little bit different, but either would work. And so I give them an informational sheet. It's usually one page front and back. I give them a prescription for 7 days. I give them a follow-up appointment, and then they can go home and do this when they're ready. It's quite easy to do, and I think it's really good for their care, and it's good for their patient satisfaction.
All right, so Nick, I very much agree that being able to start folks at home is incredibly important, so that so that you're not missing opportunities to treat folks. But I want to go on to this one, which is this is like one of those questions that I think people are afraid to ask, but may frequently feel and may ask that without saying it out loud. Well, people who use drugs are breaking the law, aren't they? Many folks are using non-prescribed drugs, illicit drugs. Why should we be treating this medically? Isn't this a police-related issue? All right. And what I can tell you is, well, we had a part in developing this issue. So I'd like to review with you the increase in opioid overdose deaths. So I want to start from a moment of humility, because I have practiced since 1999, and there was a significant increase in prescription overdose deaths starting in 1999 and really dominating until about, we started seeing some changes in about 2010, but the peak prescribing for opioids was about 2012. So we're talking about this massive, sustained exposure in the US population to opioids that were prescribed from us, from me, from many of us who were practicing during that time, when pain was the fifth vital sign, when we were told that opioids were safe, when we were told that there are certain opioids that were not addictive. So I come from a place where I was trying to help people. However, we were unfortunately over prescribing opioids. So we had this massive exposure in the US populace to opioids. In fact, there was about one prescription for every American in 2012. Well, then what did we see? We saw a rise in heroin overdose deaths that started in about 2010. That's that darker blue line here. And then in about 2013, we started we started realizing we have a problem here. So we started to look at turning the faucet off. So we're going to decrease opioid prescriptions. And then what did we see in this time? That purple line, which really closely resembles the any opioid overdose death line, that black line, and that purple line shows this rise in synthetic opioid overdose deaths. And that this is through 2019, but this has continued to spike. And fentanyl, again, is what we're talking about in these other synthetic opioids, causing this huge increase in mortality. So starting from the place that, we had a part in this. So from 2010 to 2014, only 11% of patients with opioid use disorder were prescribed medication. So we also, during this time where we started turning the faucet off, we weren't prescribing medications for opioid use disorder. So we were not giving evidence-based treatment. It's well established that medications are the standard of care, standard treatment for opioid use disorder. But we had one prescription for every American, but only about one prescription that's evidence-based for every 10 people that now has opioid use disorder. So this was a really huge gap that we're facing. So I really have to emphasize this quite a bit. We need to look at addiction, at opioid use disorder, not as a moral failing. We don't look at people who are experiencing opioid use disorder as criminals. This is a chronic disease that requires medical treatment. What if we made diabetes illegal? Does that mean that people would get better care? No, we need to see addiction as a moral failing. We need to make sure we're treating this as the chronic disease that it is. which has evidence-based treatment. We know that there's treatment that can help. And unfortunately, that treatment is not incarceration. So again, I want to point out this gap in care. So you may have, I started a program in my hospital about 2015, 2016. We started realizing, hey, we have a problem here. We've been prescribing too many opioids. Let's do something about it. Let's turn the faucet off. Let's see how we could be more mindful about how we prescribe opioids so we can decrease exposure to opioids in really in an honest effort to decrease opioid overdose deaths. And we were actually pretty good at this. You can look from 2010 to 2020 that we were able to decrease prescription opioids by at least 44% since 2011. So this is a huge reduction in opioid prescriptions in a relatively short amount of time. But what do we see here? Significant increased overdose deaths. And we've covered this a lot of times, but we've seen overdose deaths continue to increase despite our best efforts to decrease opioid prescribing. And this is what's happening. Again, massive sustained exposure of the US populace to opioids. And then we turned the faucet. We regulated, restricted, opioid prescribing without any big effort at providing better treatment. So it's a worst case scenario. Now, so what's filled the gap? Methamphetamine and fentanyl. Fentanyl has filled that gap, that vacuum that we left by turning the faucet off without filling that with treatment. All right, so I'm going to turn it over to you, Andy.
Me again. I'm excited. Let's do some pain. More pain. All right, let's get this going. What is the best way to treat acute pain for patients on medications for opioid use disorder? And this is a great question because as emergency providers, that's a real common complaint that we get. And hopefully, we're going to see a lot more patients on medications for opioid use disorder because you're going to be starting them. It's going to be more accepted because of all the great work Ariana is doing and Nick is doing. That we're going to see this, right, be more of a conundrum. But now we have the chance to talk about it and be able to anticipate it and be able to treat them appropriately as we do this. So pain control while on medications for opioid use disorder. People are going to be on methadone and they're going to be on buprenorphine and maybe naltrexone. So we'll go through those a little bit. But when people are on methadone, first of all, it may not show up on the maps. So that's one important thing to do. And then that's kind of their baseline maintenance. And if they have any painful condition on top of that, you absolutely can give them more pain medication to meet that new painful stimuli that they have, right? Do not assume that their dose of methadone is going to make them anesthetized to the world, right? They don't walk around in a state of just like pure, like, oh, nothing can hurt me because I'm on methadone. It doesn't work that way. If they have a new stimulus, then you can absolutely add opioids or whatever you need to on top of that to take care of the stimulus that they have. Buprenorphine, same thing, is that you cannot rely on buprenorphine, their normal maintenance dose, to take care of any painful condition that they might develop, right? And so, when you are looking at pain control for patients that are on opioid use disorder, or medications for opioid use disorder, you want to, first of all, alternative to opioids is great. You can maximize those. And so that can include non-steroidal anti-inflammatories like vocal blocks, et cetera. It really depends on the patient. So we're going to get into that in a second. And it also depends on the situation. So there's lots of different ways to treat different pain complaints that are coming in, depending on, again, what the situation is. So let's go through it. If they're on buprenorphine and they come in, say, after a motor vehicle collision, they broke a bone. What kind of bone? Which bone, Ariana? Which one should we do? Femur? Sounds like we'll do femur fracture. Okay, those are really painful. So someone's on buprenorphine, they break their femur, they're screaming in pain, like, what are you going to do with them, right? Well, you could do a couple of things, actually. After you set it, potentially you can do, use buprenorphine as the main controller of pain. And we do this quite often in patients. So you can split and increase the dose because the analgesic effect doesn't really last as long as the substance use disorder controlling effect. So a lot of times what we'll do is we'll take if they're on 60 milligrams a day, maybe we'll put them on like four times a day or 4 or 6 times a day, something like that. So we split it and we can increase the total amount of buprenorphine they get. And that works really well for a lot of patients, right? Another possibility is that you can just like reduce the buprenorphine dose, like maybe down to 4 or 8 milligrams a day. Don't stop it, But on top of that, you can use full opioid agonists. And so the idea is that you free up some of those receptors. This is how I think about it in my brain, is you free up some of those receptors that can utilize the full opioid agonist effect and get the analgesia that they need. Or you can stop the buprenorphine, do whatever you got to do with the full opioid agonist, and then if you have some experience in this, you can just start a micro dose afterwards, as the acute painful condition improves. And this is really commonly encountered thing that we see on our inpatient consultation service. And so this is one of the 3 ways we do it. But for you in the emergency department, what I recommend is you can absolutely just use full opioid agonists. If they just took their buprenorphine or they have a fair amount of buprenorphine in their system, just realize that if you're going to give a full opioid agonist, use a high potency agonist like fentanyl or hydromorphone, and you might have to use higher doses to kind of overcome that partial agonist effect and that high affinity receptor effect that buprenorphine provides. If they're on methadone, make sure that you don't take away their baseline dose, right? Confirm their dose, call the methadone clinic, get it appropriate. Get it appropriately, and make sure that you just maintain that dose, right? That's kind of their basal insulin dose that you want to keep going on. And then you can continue the dose, or you can split it. Same idea with buprenorphine is that analgesia doesn't last as long as for the anti-addiction effect. And so sometimes we will split up the methadone dose, and that can help quite a bit. And on top of that, after we've maximized non-opioid alternatives, we can also use full opioid agonists as needed to help control pain. Remember, they also have higher tolerance. Both patients on methadone and buprenorphine have a higher tolerance, and so you may need higher doses to get the appropriate analgesic effect and have the discussion with them. It's like an anticipation. You broke your femur. This is not a walk in the park, literally, and it's going to be painful for a little bit, and we're not going to take pain away 100%, but we can make it intolerable and make it much more tolerable. And most patients, they are very happy, having these discussions. They understand that a broken bone is not going to be an amazing thing to deal with, and then they're going to get better. So just talk them through this a little bit, but realize that you can use higher doses and you can still treat them safely and effectively. Now, if they're on naltrexone, which is an opioid antagonist, look for an armband. They usually have something on them that'll tell you whether or not they're having or they're on naltrexone, because that's a pretty good opioid antagonist that's going to make it real difficult for you to control their pain with opioids. So you really want to get creative and aggressive with multimodal pain management, again, like non-opioid alternatives. And some of the ideas here is that you can use regional anesthesia, maybe some lidocaine infusion, NSAIDs, ketamine, mindfulness, relaxation, whatever it is, right? There's a lot of things that you can use to help decrease the pain and the sympathetic surge that they have going on. Or if you really need to use opioids, then you're going to have to be prepared to use much higher doses of a highly potent medication, right? Again, fentanyl, hydromorphone, probably the higher potent ones that we're most familiar with and comfortable with. But you're going to have to use like 6 to 20 times the dose of it. And so these patients, you're gonna have to watch very carefully, and you have to be pretty aggressive and just titrate appropriately, and it can be a little bit difficult. Bottom line, you want to be aggressive. These patients deserve appropriate pain control like anyone else does. You realize that you are dealing with tolerance, right? And so this drug-seeking behavior that you're seeing is actually just relief-seeking behavior, and so it's okay to give them the appropriate dose. Don't rely on their home dose of methadone or buprenorphine to cover whatever new acute painful condition they got going on, right? Like, that's not fair to them. And then and if you're not adequately controlling pain, that's a real common reason people will say, like, screw it, I'm out. And that doesn't help them in complying with therapy. That doesn't help their overall quality of life. And that is really going to lead them to like poor outcomes, because you can see people leave against medical advice and then go overdose or sort of, self-treat because you weren't aggressive enough. And was that the right thing to do for the person? It's not something I want my family member to deal with. And it's not something you probably want to deal with yourself. So let's make sure that we do the right thing for the patient. So we have a polling question here. I'm gonna let you read through this and then come up with the answers. So we're gonna give it a pause for a couple of seconds. And we'll move to the next section. Nick, take it away.
Cool. Thank you, Andy. Okay, so often people will ask, they're worried, is there any risk medical legally if they provide someone with a prescription for buprenorphine who has a known opioid use disorder and the patient doesn't adhere to the treatment plan? So not surprisingly, like many of these patients will have repeat ED visits. They'll be concerned for, quote unquote, drug seeking behavior. Maybe they've misused opioids that were prescribed to them in the past. And so you can understand why some providers may be concerned that if they give someone with an opioid use disorder another opioid, buprenorphine, that it could be looked back at negatively and they could be, in trouble for this. The one thing I'll highlight is that diversion and illicit use of buprenorphine is often not for the reasons that people divert and illicitly use other opioids. So most 90% of a diverted buprenorphine is used to treat opioid use disorder for other people with an opioid use disorder who would report that they would like to get it through a more formal mechanism, through prescription, but often that there are barriers to treatment or there are treatment deserts that make it difficult for them to get a formal treatment plan. And so often if you're in an area where there's a lot of buprenorphine diversion, it's really a signal that more treatment is needed, not that it should be withheld. And so that's point number one, is it's not, if it's diverted, it's not that it's contributing to the, flourishing of a opioid use problem in your community. It's usually helping treat people who wish to stop using illicit opioids and unsafe opioids. I think that's the big thing too, is buprenorphine, doesn't cause this respiratory depression. It's relatively rare as a mono product to cause, or as a single agent to cause overdose. So if you're taking it with other sedatives such as benzodiazepines or other Z drugs, then you can have an overdose and have respiratory depression. But by itself, it's not causing harm when it's taken not as prescribed. So there's some safety in that. And here's the chart showing that that ceiling effect on respiratory depression. Once you get to 4 milligrams of buprenorphine, then your minute ventilation doesn't significantly decrease for a long time. Like this chart has a long tail. And so you can feel safe that even if someone takes more than you recommend, that they are unlikely to have any harm caused to them. And as long as you're prescribing the dual product with the naloxone in it, even if it's injected, that naloxone will compete when injected with the buprenorphine and make it so there's not a significant euphoric effect or respiratory depression. So overall, it's a very safe drug. What is not safe is the current drug supply. And so over the last year, 80,000 Americans have died from an opioid overdose. We know, as Ariana had reviewed, that the 1-year mortality after an ED visit for an overdose is 5%. So ACEP has guidelines, and AAEM has a white paper suggesting that we provide medications for those with an opioid use disorder and a prescription until follow-up can be attained. And we know that our colleagues are writing buprenorphine at an increased rate. So I think knowing the dangers of the ongoing drug supply and the opioid epidemic, with the high morbidity mortality of opioid use disorder, really pushed our organizations to suggest that we do this, and people are doing it. So this should really be protective medical legally. What is not safe, in my view, medical legally, is to not prescribe medications. And so there are recommendations from the Legal Action Center. Like here is, I think it's 60-page guideline about how hospitals, emergency departments are violating federal law by not providing medication treatment for those with use disorders in their departments. And so as it stands, I don't know of anyone who has been successfully sued as an emergency physician or emergency provider for not providing medications, but I think that time is coming. It's becoming more common that we're giving medications for opioid use disorder. Our national societies are recommending we do this. And so I think the risk really is in not doing it rather than giving prescriptions. Ariana, it's back to you.
All right, great. Thank you, Nick. So I'm going to talk about, I have to mention that we frequently get stuck here. So the question is, can we start a medication for opioid use disorder treatment pathway without a screening protocol or question? And this question becomes important because I have worked with a lot of emergency departments that get stuck. Well, did you put a question in triage? And I know I can't see anybody who's watching this right now, but raise your hand if you've been yelled at for all the different screening questions in triage. If anybody's worked out in triage, they have to ask so many questions. It's really can become very cumbersome. So I can tell you that at my hospital, we've been providing medication for opioid use disorder for quite some time now without having a screening question. So we just added a screening question about 3 months ago, only by getting rid of one screening question and then replacing it with the NIDA one question quick screen. We added that. But so let's answer this question just through some evidence. So when you look at the consensus recommendations on the treatment of opioid use disorder in the emergency department, and this was published last year by a group of folks that I have the utmost respect for, what I didn't find in there is the need for a screening question. So, when we look at all of the things, the recommendations on the treatment of opioid use disorder in the emergency department, there is consensus on providing medication, on referral to treatment. There's a lot of consensus on what we should be doing in the emergency department. But again, this is not all rooted in finding that perfect screening question first. So when we also look at perspectives about emergency department care encounters among adults with opioid use disorder, we look at the different things that make a really big difference. And yes, participants described stigma, the need for access to on-demand opioid use disorder treatment, referral, making sure emergency department staff is trained. But again, requiring a screening question did not move the mark. I actually have a friend who just worked on a grant where their entire grant was about developing that perfect screening question. And they took an entire year and put in a screening question into their EMR. This is an outpatient clinic. How many new patients do you think that they attracted with that perfect screening question? It was a big old donut. It was zero new patients with the perfect screening question. So could it be a part of trying to make sure we're inclusive and capture folks who may not realize that we have a program? Yes, but should we halt or pause any program until we have a screening question? Absolutely not. So this is another one that Andy and I like to talk about just because there's so much fear about flooding the market with buprenorphine. And this is what I call pill in the pocket. So in France, they were actually dealing with a pretty significant HIV epidemic. This is in large part was attributed to injection drug use. So this is dating back into the 90s. I was just graduating high school in those early 90s. But in France, they were actually identifying that buprenorphine was a good way to go to help curb the HIV infections and death. So what they did is they made buprenorphine highly available. Again, no screening question required. They just made it really available. So they made it available in pharmacies without a lot of regulations. So somebody literally, today, I could go into a pharmacy in France And, if I have opioid use disorder, I can go in there and say, hey, I'm struggling, I need buprenorphine, and they can give me a dose of buprenorphine from the pharmacy. I don't have to go to a separate visit at a specialized clinic. I don't need an X waiver, so a provider with an X waiver to give this to me. It can be given to me in a pharmacy setting without all of those hoops to jump through. So, what happened when they made buprenorphine widely available in the late 90s and early 2000s? Well, that dark line is a heroin overdoses. That grayish line is buprenorphine. So, as buprenorphine administration went up, heroin overdoses went down significantly. So again, not basing everything in a screening question, but just making sure we get buprenorphine out there. And if you are working on a screening question, it should be to make folks aware that you can offer it without jumping through a lot of hoops. So again, really want to drive the point home. If you're going to talk about screening, first make it safe for folks to disclose this very highly stigmatized condition. Work on stigma within your emergency department so folks feel comfortable telling you that they're struggling with opioids and come forward and you're able to treat them. It actually makes your clinical life easier because rather than folks coming in really looking sick, sweaty, writhing around, complaining of abdominal pain, if you make it safe for folks to disclose this highly stigmatized condition, you'll be able to treat them with what they need. So if they are able to tell you they are in opioid withdrawal and know that you're going to treat them without stigma and treat them just like you would with other medical conditions, then you are going to find more folks who disclose this to you. And again, it'll make your life easier. So focus on getting the word out that you're going to treat folks with evidence-based compassionate care. All right, I'm going to turn it back over to you, Andy.
All right, thank you very much. All right, next question. Can I give buprenorphine in the ED even if I don't have an X waiver? Let's get into it. Well, let's just read this one out loud. This is from your 21 CFR 1306.07. I'm sure you're all aware of it and read it multiple times before, but it says nothing in this section shall prohibit a physician who is not specifically registered to conduct a narcotic treatment program from administering, but not prescribing, narcotic drugs to a person for the purpose of relieving acute withdrawal symptoms when necessary while arrangements are being made for referral for treatment. So the answer I got from this is yes, right? Not more than 1 day's medication may be administered to the person or for the person's use at one time. Such emergency treatment may be carried out, blah, 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 blah. So there's your answer. It's right there. Heck yes, you can. Consider giving larger doses. We're going to get into that. This is for the non-waivered physician. And then I want to reinforce the fact that patients can return for additional doses. But you can make all of this so much easier, but just applying for your X waiver right now. This is the notice of intent, and here is the website that you go to. It takes, I don't know, 2 minutes and 37 seconds. Is that right, Campbell? I haven't gone through it. I think I want to do a stopwatch at some point, but once you do it once, you can't do it again. So it's kind of break into my partner's thing and then just make them or do it for them. But going back to like we were talking about, maybe you give higher doses, like maybe that's a good idea. And so you can take a look at what this looks like. So how do you make like a single dose act for longer than just, the single dose that you're talking about before? So when you're looking at buprenorphine maintenance, plasma concentrations, and how much that you're giving, I think Nick already went through that this is like an incredibly safe medication, right? That you really don't run into, respiratory depression because of the ceiling effect that you already have on it. It's wonderful. And what you can do is you can really, by giving a big slug up front, is that you can prolong the amount of time that they have buprenorphine in their system, kind of creating your own depot effect, if you will. And this can be really good for patients that are going to go to jail for a period of time, or they're looking at the weekend or what have you, that you can just get these higher doses that their plasma concentration can be higher for a number of days. And so that is great. Oops, may have skipped one. Yeah, and so here's like some practice guidelines here. If you want to put your phone up to this QR code, this is the California Bridge Guide for HHS practice guidelines for the administration of buprenorphine for treating OUD, in case you don't believe what my face is saying to you right now. And so that was a really easy section. I'm going to hand this one over to Nick again.
Thank you. This last frequently asked question. Often this is from my residents or students. So is there a way to treat someone in naloxone precipitated withdrawal? So someone's not breathing very well, they look blue, they have a history of drug use. So EMS, gives them 4 milligrams of naloxone and wakes them up. Now they're breathing, but they're very uncomfortable. They're tachycardic, they're diaphoretic. They just don't look well. They're throwing up all over the place. Fortunately, naloxone, goes away in 45 minutes or so, but is there a way to make them feel better and then also start them on treatment? And sometimes we can do two things at once, and this is one. So if someone receives naloxone, that has a 5-fold higher mu opioid receptor agonism than morphine. So it removes the morphine or heroin. It works less well against fentanyl, but still work. But then buprenorphine has a 6-fold higher mu opioid receptor agonism than naloxone. So it can remove the naloxone so that they feel better. It's a really good opportunity to make them feel better, plus also start them on medication that then can be continued so they don't have an opioid use disorder anymore. So of course the patient, should be aware of what you're doing. They should be able to consent that they want this medication, that it may mean that if they go out later that day, they won't get any euphoric effects from their medications or from their drugs. But assuming they can give consent, it's a great time to treat them, even if they don't have an intention to continue long-term. So if you're just giving doses of buprenorphine to get rid of their naloxone precipitated withdrawal, but then they don't want to go on it anymore, that's okay too, because then for the next 24 hours, they're relatively protected against overdose. And as Ariana had presented, that first 24 to 48 hours is a very dangerous time after overdose. And so even if you can protect them for the next day or two, that's great. Here is a California Bridge guide about how to do this. As I mentioned, if you suspect or they report overdosing on heroin or fentanyl, and they aren't on any long-acting medications like methadone, they aren't any other co-ingestions like benzodiazepines, they can give you consent, seem to understand what's going on. They have some withdrawal, right? You don't want to give it to someone who is no longer in withdrawal, because then you could put them in buprenorphine precipitated withdrawal. But if they're still in naloxone precipitated withdrawal and they're agreeable for treatment, you would give them 16 milligrams, which is higher often than what we do. But remember, it's competing directly with the naloxone, which is a high affinity for the mu receptor. And then you watch them for a while, make sure they don't get worse again. And then you can either give them a prescription to continue, or if they don't want to continue, that's fine. Try to counsel them too, but at least let them know that they'll be protected from overdose for the next 24 hours. And so it's that simple. I've done it once. It was great. I've tried to do it a couple other times and the patients weren't interested, unfortunately, but it's something that I do attempt to do if I have the experience of caring for someone who is in naloxone precipitated withdrawal. All right. Thank you all so much for your attention and time today. I want to thank Dr. King and Ariana Campbell for their expertise in sharing their information. It's always wonderful to be on a meeting with them.
Thank you. Super fun. Oh,
we have one more polling question. I'll let you read that. I'm going to pause for just a second and we'll go to our references page for you.